a little briefly. Um, and we got some dynamic speakers on tonight, as we do throughout the rest of this year. And so, since June is Men's Health Month, um, our first speaker tonight actually is going to be Mr. Tim Story. He's a registered nurse at the VA hospital and in our telehealth department. And our second speaker at 7 o'clock will be Erica Pierre, and she's a registered nurse for the Christus Health Department. So, without further ado, Mr. Story, if you want to go ahead on and turn it over to you now.
Thank you, James, and thank you, Pastor Scott, for the invitation tonight. I really appreciate it. Tonight, like James was saying, I am a registered nurse. I've been a nurse for 27 years, 15 of which were at the bedside in the critical care areas. And the last 17, I've been tied in with telehealth in some form or fashion, either doing home telehealth or working in the telehealth program. And now I'm actually the supervisor over the program. And what I wanted to talk to you all about tonight, since this is Men's Health Month, is I wanted to talk to you about your eyes, your vision. And the central question that I'm wanting to ask is, do I need an eye checkup? And I'm going to share my screen. And y'all let me know if you can see it.
Yes, sir.
Are you able to see that? Very good.
Yes, we can.
All right. First things first, just a little disclaimer here that this presentation is for informational purposes only. It's not meant to diagnose or to treat or to say that you have any issues or symptoms or anything of that nature. Please see a qualified eye specialist if anything comes up within this presentation that gives you pause or causes you to question something that may be going on with you, okay? I wanted to talk a little bit about the structures of the eye real quick, and just moving from the left to the right. The cornea is actually the outer portion of our eye. It surrounds the pupil and the lens. This gel that's inside of the eye, you'll hear me talking a little more about this. That sometimes we can get floaters in our eyes, and I'll explain some of that. And then some other very important points to make is the retina, the macula, and the optic nerve. These are all primary central things that we need in order for our vision to function properly. And we're going to talk more about some of these as we go forward. Okay, so when we actually see an image with our eyes, it comes in through the front of the cornea, and then it's flipped, and it sets on the back of the eye, where there are cones and rods. These cones and rods help convert the image into a signal that then goes to the brain for interpretation. And this is basically how it happens. And I'm mainly focusing on the big portion of the screen. You see an apple, it comes in with the light and it's reflected on the back of the retina, and those cones and rods interpret it. And this is all happening within a matter of milliseconds. They interpret it, they send the signal on through the optic nerve, and then it goes actually through the visual cortex, which is in the back of the brain. I don't know about you, but I was shocked whenever I found this out. I thought our vision was more towards the front of the brain, but it's actually not. It's actually in the back of the brain. Any questions about those few structures? Anybody have anything they need to ask about that? All right. There's three common types of processes, disease processes that I want to talk to you about tonight, just briefly. The first one is diabetic retinopathy. And the name of that kind of gives it away. This occurs in patients who have diabetes. The second one is an age-related macular degeneration. We'll talk more about that. And then there's also glaucoma. And as most of you know, glaucoma starts on the outside of the eye, on the outside of the pupil, not the pupil, the iris. And it actually starts to close in as the person's disease process progresses, okay? Let's talk about diabetic retinopathy. This is an eye condition that can cause loss and blindness in people with diabetes. Over time, what happens? Too much sugar in the blood damages the retina and can block the blood vessels that support the vision. Okay. Who's at risk for this issue? Anyone with uncontrolled diabetes can develop diabetic retinopathy. It's the #1 risk factor. That includes all types of diabetes, type 1 and type 2, or whether if it's gestational or not. No eye care within the last 2 years, that's a risk factor, is that you haven't seen an eye doctor or had any eye care within the last 2 years. And you've had some of the following. You've had poorly controlled blood sugars, an A1C of 8 or greater. And you say, well, what is an A1C? An A1C is a average of your monthly blood sugars over 3 months. So it's kind of hard to cheat on that one. You know, a lot of times we'll go to the doctor and if we have diabetes, they'll want to see what our readings have been for the past month. And the readings can give you an idea of where you are, but that 3-month average, it's kind of hard to get away from that, you know, because it's testing the blood to see what you've been averaging for the last 3 months. Poorly controlled blood pressure. Generally, blood pressure greater than 140/90, that really, you need to have that looked at. You need to see a doctor to get that under control, because that can lead to other issues, not only diabetic teleretinal, I mean, not only diabetic retinopathy, but other things as well. And then some females with pregnancy also develop diabetes, and they also need to follow up with their doctor every trimester. So what are some of the symptoms of diabetic retinopathy? Early onset, there's usually no symptoms whatsoever, which that's why it makes it the most important time to start yearly eye exams for early detection, because the earlier you can detect this, the quicker you can get treatment and help slow the progression. Some people notice changes in their vision, like they have trouble reading or trouble seeing faraway objects, and the changes can kind of come and go. In the later stages, you may start to see, this is what we were talking about, the floaters or dark spots and possibly streaks that look like cobwebs. So this is what vision with diabetic retinopathy looks like. And you can see on the left side is a normal vision. On the right side is an eye that has been affected with diabetic retinopathy. And you can see there's no set pattern for this. It affects central vision. It affects peripheral vision. It covers all of it. What are some of the treatment options? Early treatment, like I said, is the key to prevent disease progression and loss of sight. Once the damage is done, it is irreversible, but your doctor can help slow down the progression. How do you do this? Regular eye exams, most exams are set up for diabetics within every 1 to 2 years. Some are 4 to 6 months, depending upon the severity of the retinopathy. Whenever you finally go into the doctor to be seen, it's treated and it's diagnosed usually by a dilated eye exam or an eye screening with imaging and eye pressure measurements. We do this at the VA. So if you're a veteran, I would highly recommend that you do it. It's painless. It doesn't hurt, and it can be done within about 30 minutes. Now, if you go to the eye doctor, they will put some drops in your eye. They will dilate your pupils. It'll probably still take about 30 minutes for them to complete the exam, but they will dilate your eyes, and someone will. I'm trying to remember. I don't think anybody has to go with you. They'll give you some dark glasses to help you out in the sunlight whenever, or bright lights, until the effects of the drops wear off. Meet with your eye doctor and let them help you set a personal A1C goal, because anything greater than 8, you're in danger. Do they, depending on the progression of your disease, they may want you at 7 or 6, somewhere down like that. So, but otherwise, if you don't meet with them, do the best you can to keep your A1C below 7. High blood pressure and cholesterol with diabetes increases your risk. You see your doctor about controlling your blood pressure and your cholesterol. Those are two very important things, not only for your eyes, but for your heart, for your kidneys, for multiple other things, okay? They can also do laser treatments to reduce swelling and make blood vessels shrink and stop leaking. And then lastly, there's always eye surgery if you have scars in your eyes. What are some common reasons for avoiding treatment? The first one, fear of the unknown. Don't ask, don't tell. If we don't want to know, we don't ask, we don't go find out. There's generally no symptoms. So in the early stages, so we tend to think that everything's okay, and it may not be. If you're scared of a dilated eye exam, it does not hurt. It's a part of a comprehensive eye exam. They put drops, like I said, in your eyes, and it doesn't take that long to complete. They're not going to be poking you or sticking anything into your eye. It's just they're going to they're just going to dilate your pupils, and that'll be it. Younger people with high blood pressure tend to avoid blood pressure medications out of fear of ED and other side effects. So that presents a problem. And so if you do go see your doctor and you're experiencing some of these side effects, I would recommend that you go back, see your doctor, let him know, and see if there's another option that you can take. But it's important that you address your blood pressure. Most people don't like to take blood pressure meds or cholesterol medicines. People don't like taking medicine every day. And I know this to be true because I'm one of them. I hate taking medicines, and I've got to take them every day. All right. So let's talk a little bit about age-related macular degeneration. This is an eye disease that blurs your central vision in the middle of your field of vision. That's where this affects the most. It doesn't cause complete blindness, but it does make it harder to see faces, to read, to drive, to do close-up things, like for us, like screwing in using a screwdriver to screw something together, or hitting a hammer. For the ladies, trying to thread a needle, that would almost basically be impossible because you can't see. You'd have to hold it out to the side and try to do it, and it makes it very difficult. Cooking or fixing things around the house could also become very difficult. What causes age-related macular degeneration? First off, it's the leading cause of vision loss in older adults, but it occurs with aging and causes damage to the macula, which is in the back of the eye right above the retina. Some risk factors for age-related macular degeneration are people over 55. They're more likely to have AMD. If you have a family history of age-related macular degeneration, I strongly encourage you to go and get your eyes checked, because a family history, genetics is a very powerful thing. And if anybody in your family has issues with their eyes, please go and get an eye checkup. If you are Caucasian, this affects more Caucasians than any other group of people, especially if you have a history of smoking or tobacco or nicotine use. That includes vapes or anything like that. If you're overweight, you have an abnormal body mass index, or if you have a history of coronary artery disease. Some of the symptoms related to age-related macular degeneration, it depends on when it's discovered. If they discover it early on, it's usually what they call a dry age-related macular degenerations. There's no symptoms noticed at this stage. In the intermittent stage, you still have some symptoms, but others may verbalize mild symptoms like blurriness or their central vision or trouble seeing in dimly lit areas. Example like night vision. Have you ever heard somebody say, I've got bad night vision while driving? This could very well be one of those things that causes that. It doesn't cause it, but it could be related to that. And then if you're in the late stage, straight lines will appear wavy or crooked, and worsening blurriness to the central vision, usually taking up more of the visual field. Color blindness and seeing in low lighting is just about impossible. This is how someone sees with age-related macular degeneration. Excuse me, just one second. All right. Normal vision on the left, but on the right, you'll notice the picture is much more blurrier, and the center part of the picture you can't see. That's because that area of the macula has been affected, okay? Treatment, of course, with all of these, it's going to be a dilated eye exam or advanced imaging of the inside of the eye. It's simple and painless. Treatment depends if it's caught early, intermittent, or late. If it's caught early, there's generally no treatment at that stage. You just need to follow up with your eye doctor either every 1 or 2 years. The most important things are eating healthy, getting regular exercise, and quit smoking. For someone in the intermittent stage, you would treat this with injections and laser treatments. And then in the late stage, there's currently no treatment options available, okay? So why would people avoid this type of treatment? Fear of the unknown, again, little to no symptoms in the early stages. Fear of injections and laser treatments to the eyes. I know I fear that. I don't want nobody sticking anything in my eye, but know this, they give you drops that numb the eye. And so that helps it, helps a lot. Because nobody's going to sit still and just let somebody poke them in the eye without some type of numbing agent to go with it. Financial is a big reason. A lot of people don't have the money to pay for services for an eye exam, or they don't have insurance to cover, so that affects the amount of access you have to healthcare. Again, fear of dilated eye exam. And most people don't like to take blood pressure, cholesterol medicines every day. All right. And I included this little slide up over to the right with this particular disease process, because this is the only one that you can actually see an external symptom of. You don't see anything with, like if I was looking at you, I would not know if you had diabetic retinopathy or if you had age-related macular degeneration, because those things are on the inside of your eye. Glaucoma, however, also affects the inside of the eye, but there are symptoms, and you can see where there's like a little white cloudiness forming around the perimeter of the eye, and it will usually continue to go around and then close in to where causing complete blindness. Okay, the symptoms start slowly. You may initially not even notice them. You just may have some blurry peripheral vision. Um, and so there's currently no cure for glaucoma, but early treatment can alter or stop the damage and protect your vision. Scientists and physicians are not sure what causes glaucoma. They do have a theory. They believe that it's something to do with elevated pressures within the eye. And that is another reason why it's very important to control blood pressure. There's currently no way to prevent glaucoma, so regular eye examinations are important to catch it as early as possible. While anyone can get glaucoma, some people are at greater risk than others. You're at high risk if you're over the age of 60, especially if you are Hispanic or Latino. If you're an African American over the age of 40, I strongly recommend that you get an eye exam just for a baseline, because blood pressure affects African American men over the age of 40, especially if you smoke or you vape or anything that has nicotine in it. And again, if you have a family history of glaucoma, it's very important that you get checked. If you have, that's a big word there. If you have ocular hypertension, basically what that means is just high pressures in your eye. It's only detected by gaining the pressures of the eye. And we do that at the VA, for example, with a device called a tonometer. A tonometer is a little handheld device. You put a probe in it and you bring it almost right up to your eye, and then the technician will pull the trigger. That probe will shoot out, touch the tip of your cornea, and pull back. It doesn't hurt. It just causes you to blink, and that happens, but they are able to measure the eye pressures from that point. Okay. There are no signs and symptoms with elevated eye pressures. You'll never know if you have elevated eye pressures until you go actually get seen and have someone do an evaluation. Symptoms of glaucoma early is usually none, which is why treatment is usually delayed. Usually early symptoms, you'll notice elevated eye pressures. That's one of the earliest symptoms of glaucoma that will come up. An intermediate symptom would be loss of vision, usually starting from the sides, like I said, and working its way in. And then the later symptoms cause complete loss of side vision, blind spots, and ultimately blindness. This is what vision and the progression looks like with glaucoma. You'll see the first vision is normal, and then the second one is early stages of glaucoma, where the outer perimeter has been affected. And then when you see advanced glaucoma, it is actually closing and leading to complete blindness. Okay. Treatment of glaucoma, it's just like everything else. And I hate that it's this way, but just about any type of eye problem is going to be detected with a dilated eye exam or advanced imaging. And also this particular, if they find it, they will also do a visual field test to check your peripheral vision. There are 3 treatment modalities for this. Early is eye drops. you may have, you may know somebody who uses eye drops, lowers their eye pressures. It's very important that they take these every day because you want to keep the pressures of the eye down to control the deterioration of the vision, okay? Intermediately, there's laser treatments to lower eye pressures and can help fluid drain out of the eye. Treatment can be done in the office. So, and then lastly, if medicines and laser treatments don't work, your physician may opt for a surgical intervention, which they do. They go in and they drain the fluid of the eye. Okay. Be sure if you go and you get treatment for any of these, early, intermediate, or late, tell your doctor if you have treatment side effects like burning, itching, or pain. Be sure to get regular checkups and encourage family members to get checked up as well, as glaucoma definitely runs in the family. And again, lastly, reasons for avoiding, it's fear, little to no symptoms, fear of laser or surgical interventions, finances, and fear of a dilated eye exam. I'm just trying to put your mind at ease that there's no reason to be fearful of a dilated eye exam. It absolutely does not hurt at all. It takes about 30 minutes. And here's where I pulled that information from. Does anybody have any questions related to this?
I remember just you mentioned, what was the A1C, that number that you wanted to make sure that we were?
You want to make sure that you're less than 8.
Okay. Thank you.
A1C is less than 8. Now, it would be better if it's less than 7, but really you might want to talk to your eye specialist to say, hey, looking at my eyes, can you tell me where I need to be on my diabetes, so that, because he may say it might need to be 6.5 to 7, or it might be 7 to 7.5. But if you don't see anybody, and you don't get checked up, at least keep try to keep those blood sugars less than your A1C less than 8.
Okay.
And
Thank you.
the less time that you spike your insulin, the better. So very good. Well, all right. I thank you so much for giving me this opportunity
Great
to speak
job.
with you. I hope that you've learned something,
Yeah.
and y'all have a great night. Okay.
Thank you very much. Thank
You're
you.
more
Thank
than
you, Tim.
welcome. Thank
Awesome.
you.
Thank you, Tim.
All right.
And I'll just add to that before we introduce our next speaker. I remember taking an eye exam, and I did not know I had the dilated eyes, and they told me, and the doctor told me I had allergies. I never knew I had allergies. I've never taken anything for allergies, but they were able to see that in my eyes. And so it's very important that we get checkup with our eyes. There's so much information in our eyes that we can use. And so our next speaker is, again, our registered nurse, Miss Erica Pierre. Are you on, Miss Erica?
Yeah, she's on.
Okay.
Yes, I am.
Yes, ma'am. If you would like to go ahead and start, I know our time is precious. You can go ahead and present.
Okay. I am on. Can y'all see me?
We can't see you. We can hear you though.
Okay. Let's see. Let's see. Sorry, y'all, just give me one moment. I'm on here trying to see. So I have the video on. Can you hear me?
Yeah, we can hear you.
Okay, I have, for some reason, here we go, I think. Is there a way that you'd be able to click it over to me to show the slides?
Yeah, you have access.
Oh, I do, okay.
You have to
All
do a
right.
screen share.
Okay, there you go. Okay, very good, screen share. Hold on 1 second then, okay? Because I thought it was gonna be up already. 1 second then.
While she's trying to pull that up, excellent job with this. I'm so happy that we are, really focusing on making sure we take care of our health, especially with men. A lot of times, by the time you finally go to the doctor or physician, hate to say it's too late, but that's what normally happens. So very, very, very good job with that, Brother Jordan.
Y'all, I'm gonna, while I'm doing this, I'll kind of get started just with the initial information here, and then I'll pull this other screen up. Pastor, would you be able to pull up the information that I sent to my brother James?
Yeah, you want to email it to me, or Brother James, if you have it, you can do a screen share as well.
Okay, let me try to locate it.
Okay. So while we're doing that, I'll just kind of give y'all some information while we're getting this straight. Good afternoon, everyone. Gentlemen, I'm so happy to be able to present with you all today. I think it's just very appropriate for you all to be giving this information out. I really am. I think it's very valuable information. And what I find in general, a lot of times is that a lot of times men, they don't go to the doctor quite as often. So, and that's for a multitude of reasons. Some, they just don't care to go to the doctor because you don't want them to find something, or you may not want to go to the doctor because you're afraid to go to the doctor. Sometimes it's financial reasons, but in any event, if you can, please make sure you see your physician at least once a year. I'm a nurse practitioner. I work in internal medicine at Christus, and I've been with Christus for 14 years. I've been a nurse practitioner now almost 10 years, and we see a variety. I see only adults, but what I see a lot of times is just that men are not as eager to come to the doctor. So a lot of times you are almost behind the ball with trying to figure out some of the things that's going on with them. A lot of times genetics can play a role, but you're not always destined to have the same problems that your family may have. Now, yes, genetics do play a role. If your mom and dad, they had high blood pressure, diabetes, that is definitely something that you want to always have in the forefront of your mind. But a lot of it, the reasons that we may develop some of these same problems is because we develop those same eating habits and those same, say, lack of exercise. So yes, there's a genetic component, but we don't have to eat like our parents used to eat. We can make healthier choices. And what I do find, younger people now, they tend to work out and they watch their diet much more closely than we did when we were younger. So I really think that there are some trends that are going to be very helpful, but by and large, you still have to make sure to take care of yourself and then at least go to the doctor once a year. And there are also some other things that just bad habits really put you in a bad position. Smoking is the number one cause for so many problems. Lung cancer is still the number one cancer. And it really attributes to a lot of things. High blood pressure, chronic kidney disease, bladder cancers. It's linked to a lot of, COPD. So it's linked to a lot of things. So a lot of times those things that we do to our bodies, we do to ourselves, and some of it we can get away from. Some people, 50 years they smoke and they didn't have a problem. But for somebody else, you can smoke 20 years and then have terrible COPD that's going to impair you for the rest of your life. So a lot of that just depends. It's person specific, but by and large, those things are not good. So just bad habits, smoking, drinking, drug use. And when I say drug use, I'm talking about not, marijuana, because a lot of times you don't know what marijuana is laced with. Prescription drugs, overuse of prescription drugs. I tell people there are a lot of things, that you don't know what's in something, taking somebody else's medication. Oh, this person has a hit. I see that all the time. Then they have a bad reaction and don't take anybody else's medication, take your own. And then reckless behavior, like drinking and driving, like having unprotected sex. You cannot close your eyes and act like HIV and syphilis and herpes, that they don't exist. And, for us older people, back in the day, truly, if you really weren't so much worried about, you were worried about having a baby. Now, you're teetering on your life every time you have some unprotected sex with someone. And don't think that, there are two groups between age 13 to like 21. And then also age 50 and over. Those are the highest groups of HIV. Now, you would not think that, right? Very young kids, but a lot of times these kids don't have the reference point that we do. They do all sorts of things, have sex unprotected, and then they're doing that 15, 16, 17. And then when they're 25, it definitely could be a problem. So I always try to tell people, don't make any assumptions about anything. And just for men, I always say, what looks good is not always good, sir. What looks good is not always good. All right, I got it, Brother JJ. Let's see now. Let's see if I have control. Can y'all see this? I can see it.
Yeah, we can.
Okay, can y'all give me control of it?
I could scroll down for you.
Okay, that'll be good. Yes, sir. Okay, very good.
Sorry about that.
Oh, no, it's no problem. And then, so like I said, also mental health. This is huge. It kind of goes back to the men don't want to go to the doctor because they're not sure what they're going to find, or sometimes it's just a lack of you, number one, coming to terms with what is going on with you. And then secondarily is to have enough trust in someone to say, I'm having a problem, because you do deal with a lot of stressors on a day-to-day basis, by far larger than any other group, I will say, so those things you're going to internalize, you can internalize those things a little bit better, a little bit more than someone else. You can scroll down a little bit, Brother Jay. So basically, I'll kind of give you a little perspective here. And the earlier you start taking care of your health, the better your quality of life is going to be. It is just as simple as that. If you drink, smoke, my mom and them used to say, if you drink, smoke, run to women, all these things, you're not going to live to be 70 and 80 years old. And if you do, you can really be in bad shape. So the earlier you start taking care of your health, the better. And that, we've talked about it, condom use, make sure you're protecting yourself. A lot of times people don't think that that's that big of a deal until, someone said that they've been in contact with, or a friend says they have HIV or whatever, and then they decide to get themselves checked. So let's try to prevent all of that from the beginning. Also, minimizing stress. I cannot stress this enough. Trying to get plenty of rest and taking your medications the way you're supposed to take it. So many times people have problems with, they have medical conditions, but they don't think that these medical conditions are very serious, or they don't feel like it's a big deal. Or when your doctor prescribes a medication, I don't think I need to take that. Oh, my blood pressure is good now, I don't need to take it. Well, your blood pressure wasn't good when you were off of the medicine, and your blood pressure became controlled while you were on the medicine. So you have to understand that that's why it's controlled if it wasn't controlled before. So always have dialogue with your doctor. Always have dialogue. Don't just stop those medicines right away without talking to them. If you're having side effects, they've got 100 different medicines that they can prescribe. What I find too for men, a lot of times, you know, you can have problems with erectile dysfunction with some of those blood pressure medicines. And they have some that do not necessarily have to affect your erections. You know, it's about quality of life. So yes, you want your blood pressure control, and surely you want to have a, you know, appropriate sex life, but you don't want to have a stroke in the middle because you're not taking your blood pressure medicines. And if you are on medications for erectile dysfunctions, don't not take your blood pressure medicine because you want to have sex. I see that. So I've seen that so often, and you can have something called rebound hypertension with that. So things like maintaining a good, healthy weight, I can't stress that enough. And really watching what you eat, trying to maintain a healthy lifestyle. Okay. Can scroll. So you really in your 20s to 30s, that's when you really you can start kind of your preventative screenings. When we were younger, you know, your mama took you to the doctor for your shots, and you went once a year for your annual physical before school starts. I absolutely still recommend that. And one way that you may be able to remember it is actually to get it done like on your anniversary month. You know, get it done, say, if your birthday's in November, maybe start working on that that month, or at the beginning of the year is also good. But when you're in your 20s, you know, 20s to 30s, eye exam, as the ophthalmologist said, his information was spot on there. And a lot of those conditions, you don't really have any side effects from. You can't really tell until it's too late and the damage is done. High blood pressure screenings, we've already talked about that. And then the other thing is dental checkups. Now there is really emerging evidence that shows that periodontal disease has a link with heart disease. So, and I remember when I was in nursing school the first time, we had an instructor, and she said that, and it stands to reason now, because if you think about that, that is truly like poisoning your system. So make sure you get your dental checks at least every 2 years. Now for younger men, you also have to worry about testicular cancer. Usually that is the most common cancer diagnosed in young men, 15 to 34 years old. So if you start noticing that you have a change in your size or shape or tenderness in your testicles, and you didn't have that before, you definitely want to get that looked at. Also, screenings for cholesterol, 20 and older, you do want to do that about every 5 years. Now, the significance for that is cholesterol is linked to heart disease. So some people don't have high blood pressure, but they don't have their cholesterol levels. Hold on one second. So some people don't have high cholesterol, but they high blood pressure, but they have high cholesterol, and it eventually leads to problems with heart disease. And then also hepatitis screening, and then HIV screening goes along with that too. So you definitely need to have those screenings about once a year or so. A couple of them are every 2 years, but that usually, when you go to your doctor's office, they usually cover most of that. So usually it's pretty simple. You know, how have you been feeling? Have you been having any kind of problem? And then they're going to start going down the list of your preventative care. Now, in your 20s, you can go down. There are some vaccinations that are very helpful. And I know a lot of people have a lot to say about vaccinations, but this is what I say. I deal in fact. And what I know about these vaccinations, the ones we're talking about in particular, HPV, one of the leading cause is, well, the HPV is the HPV virus, human papillomavirus, basically the wart virus that is, that causes genital warts. Now, what they're saying is this HPV can be linked to head and neck cancers. So we have a vaccination for that. It's for boys and girls, and usually get that under the age of 26. Now they just actually raised that age, but just for these purposes, we're going to say 26, but now the age has been raised. But this is good to get these kids, because the thing is, you don't know who the children are, who your kids are going to come in contact with, and then you don't know who they've been in contact with. So you could actually have a daughter that has remained abstinent until she's gotten married, but maybe the male that she is going to marry may have had multiple sex partners. And the more sex partners you have, the higher increase for HPV, which for men, there's not even a test to determine that. You just, a lot of times you don't even know that you have it until you develop the warts on your penis, you know? So those are really good to make sure to have. Also the tetanus, flu, you know, obviously the COVID-19, and then your regular measles, mumps, and rubella. So those things are really good vaccination wise. And like I said, when you go to your doctor's office, they usually cover that. Okay. Now, this is kind of for most of us now in the 40s. So I tell people this is when things get real, you know? This is when you're starting to notice, oh, maybe my blood pressure's creeping up. You've gained a little bit of weight. Your vision is not as sharp as it used to be. You know, you're kind of getting a little bit tired at the end of the day. Well, it's still not too late, okay? Even in your 40s, you can still determine that the things that need to be checked up on, and if something is a problem, most things are easily treatable. Again, blood pressure. This is what now we're going to be doing a little bit more detailed testing, like definitely going to be checking for your blood sugar to make sure you're not a diabetic or cholesterol problems, and may be doing a stress test or an EKG, a chest x-ray if you smoked for a long period of time. And this is where we do the screenings. The screening tests are key. So the colon cancer screening, usually it used to be 50 and above. Now what they're finding with good, and I'm so glad this is the case, because I was actually doing this before. African Americans have a very high incidence of colon cancer, and then we're tending to get it earlier. So I tell people, I've got a brother that had colon cancer at 44. So his kids need to be tested 10 years sooner. That's very young. So guess what? The recommended age doesn't even start until 45. But when you go to your doctor's office and you say, hey, you know, my brother had colon cancer at 45, red flags are gonna come up to him, because he knows we got to get you screened sooner. And one thing I will tell people, that if you have, being that I have this information, I'll fight with or plead my case with the insurance company, because it stands to reason that if we can get to you earlier with a colon polyp that's cancerous or precancerous, because all colon cancers start as a polyp. Okay, so if you can get your colonoscopy before or at 45, then what you can do, if they have polyps, you can get that taken care of. You know, you can get the polyps removed. They test it to make sure it's benign. If you have several of them, they'll get you to come back in a couple years, and they're going to be right on top of that. Versus, you know, your first colonoscopy at 55, where you're 10 years down the road and you're very likely to have polyps, but that doesn't mean you have cancer. Okay, so it's really good to still keep on track with that. Diabetes screening, we said, blood pressure screening. There also is a condition called prediabetes, or metabolic syndrome, where that's very common in your 40s. And basically, if you have someone that has a little bit of higher blood pressure, a higher BMI, and a borderline blood pressure, 9 times out of 10, if you were to check their A1C, Pastor, what the doctor said should be under 8, preferably lower. Well, that is a reading between 5.7 and 6.4. So 6.5 is diabetes. So there's a range, like I said, 5.7 to 6.4, that's in that pre-diabetes range. This is where you need to really start making the diet and exercise change. You don't always have to be on medicine, but you do have to get serious about the diet and exercise. And if your doctor says lose 30 pounds, really try to get that off, because that can stave off diabetes for 5 years, you know? So a lot of times people don't want to, you can't say you don't want to take medicine and then not do what you're supposed to do to try to, for the doctor to tell you to do this so you can prevent taking the medicine. You know, if you don't want to be on medicine, then do what you need to do. Exercise, diet, watch your salt, you know, watch the carbohydrates, make sure that you are leading a healthy lifestyle and lose that weight that he wants. And a lot of these diseases are weight specific. You know, I know in our community we have where, you know, we may be a little bit heavier, say, than somebody else, but that does eventually cause a problem. Obesity is related to a lot of problems: diabetes, high blood pressure, heart disease, strokes, and cancers of all types. And then one is the prostate test. Let me tell you, you go to your doctor, they're going to tell you that, well, you know what, it's an informed decision making, because there was something that came out, or a study came out a couple of years ago, or actually about a year ago. And it said basically with the prostate, they don't want you to recommend or to just basically take the PSA test. But I will tell you this, just like anything else, it's better to be on top of something than be hit with something blind. So it's something called shared decision making, that when you talk to your doctor, he may say, you know what, you're 45 now. And that's another one. We're seeing prostate cancers earlier, you know, along with the colon cancer. So I would recommend at 45, start those screening processes. And you talk to your doctor. Doctor, I have a family history, you know, I got a brother or an uncle with prostate cancer. Well, you know, his antenna is going to go up, because that's something that we really have to watch out with you. And I do recommend the prostate screening test. I do. Some people are going to say, well, you know, it may be positive. It may be positive and it might not be. It may just be from, you know, an enlarged prostate. But guess what? It could be from cancer. And you would want to know the difference if it's a stage 1 versus a stage 4. So that's why I definitely recommend that. And the last couple of the shingles vaccination and the pneumonia vaccination in your 50s, that is definitely something to consider. Shingles, it can be very debilitating. Very debilitating. If you've ever seen one, it's very painful. And the vaccination that we have right now, it's a Shingrix. I definitely recommend it. It's a 2 series. You take one now and then another 2 to 6 months. From there, you don't have to take another one, and it's above 90% effective. So it's above 90% effective in staving off shingles, period. But the less than 10% or 10% that may get it could get a very mild case of it. And if you've ever seen shingles, it can be very debilitating. You know, so it's not always that something will kill you, but it can make your life miserable. You have to take off a lot of time from work, and you can have long-term side effects with it. Now, as we're in our 60s, again, you know, things could kind of change. We may have a little bit more trouble with diet, exercise. You may not be moving around as much. Men need to be tested for sleep apnea. If you snore, you're having, it's called daytime somnolence, where you're tired during the day. This is the dad that the moment he comes home, and the wife's fixing the food, and before you know it, he's talking to you and he's sleeping on the sofa. Okay, or you can hear dad at night from across, down the hall there, and he's snoring and he's having these periods where you got to go and shake him, and his wife can't sleep because he sounds like he's choking. Now, that is what Reggie White died of, and that's what Gerald Levert died of. And I tell people, there's no such thing as just a little sleep apnea, because with the right mix, sleeping medicine, you go out with your friends and you drink, or in Gerald Levert's case, he had sleep apnea, he had a cold, he took some cough medicine, didn't put his CPAP on and died. So it does not, it just takes the right mix for you to get into a problem with the sleep apnea, but that is so high of an incidence, and people that not only overweight people, but you have to look at your neck circumference. If you've got a neck circumference above 16, you are at risk for sleep apnea. So, and women can get it too. Okay, so anybody that has that loud snoring, we call it disruptive snoring. They can, if you see you're at the light, you trying to fall asleep. Every time somebody's in the car, your wife is driving, you falling asleep, you definitely want to get sleep tested. And some of those they can do in the privacy of your own home if your insurance would approve that. But if it's for you to do the CPAP, the testing, if they determine that you do have sleep apnea, you would need to go to the sleep center to do that. But I definitely recommend that. And I think that is so underdiagnosed that I do see a lot of people with a lot of problems with that. And that causes problems with the heart and lungs. And that does increase your risk of stroke. Anytime you are not breathing well, your heart's not getting enough oxygen, your brain's not getting enough oxygen, it is at risk for a complication. And we talked about the pneumonia vaccination. This is one other thing that I see a lot of times is underutilized. If you have a man that has a history of smoking at any point, and you put high blood pressure on there, but you don't even have to high blood pressure. If you've been a smoker between age 65 and 75, you really need to get something called an abdominal aortic aneurysm screening. That's an aneurysm. So you can have it in your chest and you can have it in your abdomen. The one that is more prevalent is the one that's in the abdomen. And that's when, somebody, you hear that, or they had an aneurysm, they were dead before they hit the floor. That's what that is. So a lot of times you don't have a whole lot of warnings, but we do know that people that have high blood, men in particular that have high blood pressure, they're at risk. And then just the mere fact that you've smoked puts you at risk for that. And then above age 65, falls. So if you do have parents, even though they may think that they're agile, do try to pay attention to their gait, because a lot of times they don't realize that, and they're at high risk for falls. And when older people fall, many times it's not good. They're, in addition to the falls and other health problems that they have, their bones tend to be a little thinner. So then they're at risk for fractures that'll set up a whole nother problem. Okay. So with the preventative health in your 60s, all is not lost. So to make sure that you're following up with your specialist. And then there are also some vitamin levels that you can also check. But the key is, if you're on a medicine for a particular condition, don't just stop your medicine. And if you're having side effects, you need to talk to your doctor right away. Because a lot of times it's just from lack of information. You don't realize that, this blood sugar, you're on metformin. And I hear this all the time. Oh, that's a bad drug. That causes kidney disease. No, it doesn't. If you all these medications have a place, but they do require proper monitoring. That's why you're going to go to the doctor. Or the other one I've heard is, I heard it just today, that cholesterol medicine that make you have a stroke or a heart attack. No, that's not the case. So I think a lot of it is just re-educating, talk to your medical provider. If you have any questions, please don't just stop taking your medicine. Yeah, any questions or anything that you all would like me to cover?
This is really good, Sister Erica. So you were saying, what was the A1C range again?
Okay, yes, sir. So for pre-diabetes, okay, pre-diabetes is the step before diabetes, but you want to make sure to keep track of this. That is 5.7 to 6.4. So, and diabetes starts at 6.5. So this is what I tell people. If you look at a straight line and you have 5 in the middle, right? In this particular case, the lower that number is, the better. That is more the normal range, okay? Because normally, you don't even want to be in that pre-diabetes range, okay? So you want to be lower than that. So for a diabetic, which I will tell you, diabetes, that is a bad disease. And when I say that, I hear, oh, I got a little sugar. There's no such thing. There's no such thing as a little sugar in your blood. That is just such a misnomer. And when I see that, you know what, it just devalues the significance of what diabetes can do. Because a lot of times we see, and I see it all the time, oh, my blood pressure is always this, oh, my blood sugar always runs 300. You don't even know what you're doing to your body when you see those high numbers, So 6.5, for a diabetic, that's where we want you to be. We would like you to be 6.5 or possibly even better, as long as you're not having any low blood sugar. Now, older people, that's the goal. Your goal A1C is 6.5. Now, for older people, you just say that you have somebody that's 80, okay? Well, you may not want a 6.5 for them because that puts them at risk for low blood sugar, and they're 80, their blood sugar gets low, they fall, it's a different story. So that's where it may be more appropriate, like for an 8. Now, what that doctor was talking about, 8 is not ideal. What he was saying, 8 for A1C, that tries to decrease your chances of that, your risk of worsening macular degeneration and worsening diabetic retinopathy. So still the goal is lower, but that's the highest that they want to see it. They don't really want to see it higher than that. That's what you would strive for. But when you talk to your primary care, they're going to want to fine tune it a little bit more. One thing too, for men with diabetes and high blood pressure, #1 cause of erectile dysfunction also. So that's why it's so important to get your diabetes under control, because long-term, you think about the vessels. The vessels in the heart are bigger than the vessels in the feet, right? So, and then the vessels in the kidneys. So diabetics can have more trouble with their feet because those vessels are smaller. They can have more trouble with their kidneys, so those vessels are smaller. So, high blood sugar affects those vessels a little bit more than, say, it would the larger vessels in the heart. And then the other thing, the vessels in the penis, those are smaller vessels, in comparison to the entire heart. So that's why it's important. And I always tell, it is imperative, that you do take care of these things sooner versus later, because what ends up happening, you may get to the point where it's not a lot that you can do. Your diabetes has been out of control for 20 years or 10 years, or your high blood pressure has been out of control for 10 years, and it causes irreversible damage.
Thank you. You answered my question. This is very good, very good. Right. Thank you very much, Brother Jordan. Back in your hands, Sister Erica. Great job.
Thank you all. Sorry about the video, y'all. Sorry.
That's fine.
Yes, thank you so much to our speakers tonight. And again, the information that we're getting is hitting me right in my head, even though I'm call myself taking care of myself. There's so much we don't know, and we're so, as the Bible says, we're just, we're like a grass that just kind of withers away. Our time here is so short, and so if we don't take care of ourselves, we don't not giving ourselves a chance to even have a quality of life that God wants us to have in our brief time on the earth. So I appreciate our two medical professionals sharing those things tonight with us. And as we go forward, as I wrap up, go forward again, we got some dynamic speakers that we're going to be having this year. And I do want to come forward and talk about the things that we're going to try to do in the men's department. As we all know, it's difficult to get men together, but I have been talking with some brothers who want to do some things. It's important that we stick together and have one mind and one spirit. And so without further ado, I'm going to go ahead and if there are no more questions on tonight, we'll go ahead and have our ending prayer. Dear Heavenly Father God, we thank you, Lord, for this information that you've allowed, oh God, those of you put in charge, oh God, in the medical field to give us on tonight, Lord. We ask that you help us to be obedient to things that have been said, and we will take care of our temple, oh God, that you said that houses the Holy Spirit, Lord, that we will take better care of our temple, Lord, so we can better serve you, God, because that's the only purpose of our body, oh God. And we just thank you for those, again, that have joined on tonight and those that could not join, but we can maybe share the information with them, Lord. And we ask that you will bless everyone, Lord. In Jesus' name we pray, amen.
All right, great job. Thank you all so much for supporting this. Again, this is recorded and we will have it posted so you can share with some other brothers that may not have been able to attend. So God bless you all. Thank you.
Good night,
Great
everybody.
job. All right.
Thank you.